especially those over 75. One of the things that's interesting, and we'll see how it pans out in India, when we started TAVR, we thought that it would take a certain percentage of surgeries and convert them to TAVR. In fact, that's not what has happened. If you look at this slide here, this is the US Registry Data. And what you see here is the surgical volume, at least in the first 5 years after TAVR approval, did not drop off significantly. But there was a tremendous growth in the number of patients being treated. So there were a lot of these patients that were 80 years old that weren't willing to have surgery, but they're willing to have TAVR. So instead of 30,000 patients with AS being treated, it's actually about 65,000 patients with AS that were treated. So in terms of the US healthcare system, it added a lot of patients that were getting treated, but it didn't really drop the surgical volume. Now you're starting to see some decrease in surgical volume as certain patients are switched over to TAVR. Ongoing trials in lower risk populations are going to address the potential expanded role and provide some data in terms of durability. But the evolution of transcatheter therapies has really forced the guidelines to evolve rapidly, and it has been incorporated at different risk strata. But we got here with a lot of rigorous clinical trial evaluation. There were 5 randomized trials against gold standard therapy in the US alone, with over 4,000 patients randomizing, demonstrating equivalence, if not superiority, over surgery. There are 2 ongoing randomized trials in low-risk patients, and there are multiple other registries with different devices as well as accessory devices. But these trials happened because there was a close partnership between CT surgery and cardiology, not only in the clinical trial conduction, but in the design and planning as well. And then once this technology was proven, there was a controlled dispersion of a truly disruptive technology. And there were a lot of data. This is the initial data in intermediate risk patients showing that TAVR is comparable to surgery. Numerically, the outcomes were a little bit better, but not significant. However, what's important to keep in mind, TAVR, what we see it is when it's a transfemoral procedure, has the best outcomes. When you can do it from the groin, you can do it awake, patients go home within a day or two, that's a very different procedure than alternative access. So in the same intermediate risk trial, if you look at the transfemoral cohort, TAVR was actually superior to surgery. Now, that was not the trial design, but this was still 1,500 patients that were randomized in the transfemoral cohort, and the outcomes were superior to surgery in terms of death or disabling stroke. And then when you looked at the Sapien 3 valve, the outcomes were even better. The mortality was lower than surgery. Now, this was not a randomized trial, but it was a registry. Mortality 1.1% versus 4%, stroke 1% versus 4.4%. And so where we really stand is TAVR in these elderly patients does have a mortality benefit versus surgery. This is not a randomized trial, but it's as close to it as we can get. And the reason this benefit occurs is it occurs in that first 3 months. There's this separation. And the reason that this separation occurs in the first 3 months are several important complications are lower with TAVR than surgery. Stroke, we talked about. Disabling stroke, 1% versus 4.4% at 30 days. And then life-threatening bleeding, about 75% lower. AKI, about 60% lower. AFib, also about 60% lower with TAVR than surgery. So those 4 things, stroke, bleeding, AFib, and acute kidney injury, have been shown to have worse outcomes in surgery. Those 4 things are lower with TAVR than surgery. And that's why you see that separation at 3 months. And it's an earlier recovery. And now the one limitation, though, is we don't have a long-term durability data. The second large randomized trial in intermediate risk patients was with core valve, again showed equivalence to surgery. So from the beginning, when we talked about TAVR, stroke was initially a limitation, but the current data says it's at least equivalent, if not better than surgery. Vascular and bleeding complications were initially very high with large sheets. Now they're down to 14 French. They're not as much of a limitation either. Conduction abnormalities are still higher with TAVR than surgery. Pacemaker rates, left bundle branch block, which may have long-term consequences, especially in patients with depressed ejection fraction. That may be a limitation of TAVR in certain patient populations. But the big still concern is durability. And there are reasons to be concerned about durability. We know that certain surgical valves are not as durable as other surgical valves, and surgical valves have been taken off the market. And there's a real science to engineering these surgical valves. And slight changes in valve design can impact durability. This is a modeling study by Wei Sun at Georgia Tech, who's a biomechanical engineer. And if you make these valves asymmetric, the leaflet coaptation is impaired and leaflet strain is different. And so especially in bicuspid valves or asymmetric calcium, these valves may not be perfectly circular, and that may impact durability. And in fact, if you look at this simulation, surgical valves have nice, even distribution of stress across the leaflets. And that's one of the keys to valve durability. But when you look at TAVR valves in this simulation, the strain patterns on the leaflets are going to be higher. And this is especially true when the valve is circular, the strain is lower. But when it's oval, the strain on the leaflets is much higher. And this is going to impact durability. And so, again, this is something that it's probably not going to be as durable as a surgical valve, but it may not need to be. But we have to keep that in mind. This issue of leaflet dysfunction, leaflet thrombosis, whatever we call it, is a real phenomenon. What the true incidence is, and this is where you see in this 4D CT, 2 of the leaflets are not moving well. And what the true incidence is not known. This is probably one of the larger series where they try to scan patients consecutively. It's probably in that 5 to 10% range of patients that have some degree of leaflet thickening, leaflet dysfunction at early. So we need to better identify who's at risk, what are the risk factors, and because this phenomenon goes away or does not exist essentially when patients are anticoagulated. We obviously don't want to anticoagulate all these 80-year-olds and 90-year-olds and even high-risk 70-year-olds, but we want to identify those at risk and anticoagulate those patients. But the reality is, until there is long-term, at least 10-year data in risk patients, in normal risk patients, there is always going to be concerns about durability. The current low-risk and intermediate-risk trials are going to follow patients out to 10 years. So we'll eventually get this data, but we don't have it yet. But one of the things that's been true about transcatheter valve is it's really pushed the science of following these valvular heart disease patients. This is from the Partner 1 data, the early series. But this is over 10,000 core lab echoes in over 2,000 patients. So we haven't had a valve study, surgery or medical or transcatheter, that has had this many core lab echoes. And when you look at these echoes over 5 years, there's not really a significant change or degradation. There are obviously patients that have failure modes, but there wasn't a significant change or degradation. The reality is, I'm not sure these durability concerns are going to impact adoption significantly. If there's a mortality benefit with TAVR over surgery, until these mortality lines cross, the durability issue is not relevant. And the ability to do valve in valve allows a bailout for those that fail. And so we may be understand there's going to be less durability, but the idea of doing 2 less invasive procedures may be better. And some of these durability issues may be related to leaflet thrombosis, and ongoing research will identify those at risk, and we should anticoagulate those patients. And similar to SAVR, there will be a failure rate that will be different with different devices. The reality is we're just going to have to follow these patients very closely with annual echoes. So where does TAVR go from here? One important expansion is into lower risk subsets. The Edwards Sapien 3 Partner 3 trial design was we took patients that were low risk with an STS score less than 3 as determined by the heart team, and these patients are randomized between TAVR and SAVR. The one key difference between this trial and the earlier trials is that it only allows a transfemoral arm. Because I think when we're looking at the benefits of TAVR, it's transfemoral. So this is a transfemoral only trial. So patients, in order to be eligible, have to have transfemoral access. It's over 1,200 patients. And 400 of these patients will have CT scans, not only at baseline, but at 30 days and long-term follow-up. So I think we'll help answer some of the questions of leaflet thrombosis. Medtronic is doing their low-risk trial as well. And we should have data from both these trials as early as next year at ACC in April. So the data in low risk is not far away. So it's going to help expand indications to low-risk population. It's going to help facilitate collection of long-term durability data. It's going to provide important insights into incidence, risk factors, and consequences of leaflet thrombosis. And then beyond that, TAVR has to collect rigorous long-term data. It's not just these low-risk trials. We have to get long-term data for valve and valve, for other subsets. It's going to be important. But there are other things that we have to think about but that we never really thought about in the beginning. We've got to develop algorithms to deal with concomitant coronary artery disease. If someone's going for a surgical AVR, if there's coronary disease, it's simply bypassed. But when you're dealing with TAVR and you're doing a percutaneous awake, it's not so simple. We're not going to necessarily fix all coronary disease. And early on, we sort of erred on the side of just leaving most of this stuff alone. But the reality is we may be doing a disservice, especially as we go to lower risk patients. There have been 4 studies that have looked at sort of, and these are all not randomized, these are retrospective, these are registries, but patients with a syntax score over 22, there was no difference in 30-day outcomes with TAVR, but there were worse late outcomes. So when you had a syntax score over 22, at 1 year the outcomes were worse. Now, there's a lot of confounding variables in there and something to think about. But maybe somebody that has PROX-LAD or significant coronary disease should be revascularized if there's significant territory of ischemia, as we would with any other coronary patient. And we shouldn't ignore this coronary disease. I think it may be an issue. It's going to be difficult to get randomized trial data, and it's not going to be done by the companies. It will have to be done by either large networks or things like that. But randomizing patients with CAD is difficult. The same way it is in syntax, there's going to be a referral bias. A lot of CAD is fixed outright, so whether you're going to get a true randomized trial will be difficult, but that would be ideal. And then beyond that, TAVR is going to expand into new indications. One that's already approved is valve-in-valve in the US in both the aortic and mitral position. We routinely do, for failing surgical bioprosthetic valves, we do valve-in-valve in both the aortic and mitral. Both of these are done from a transfemoral approach, either retrograde arterial for the aortic or transvenous transeptal for the mitral. The concept of valve-in-valve is quite simple. The surgical valve provides the frame on which the TAVR anchors. In many ways, it's easier than in a native valve because the surgical frame is circular. But the key attributes to get a good result is you have to correctly size the valve and correctly place the valve. And this will provide stable function and stable position and optimal function. The challenges, though, are there are a lot of different surgical valves. And they're all very different. They're very different in where the anchoring point is, where the seal is going to be. They're different in terms of their height. Some are pericardial, some are porcine leaflets. Those are all different, and they impact not only the hemodynamics, but all the acute procedural risks. For some of these stentless valves, the risks of coronary occlusion, because when you put a Sapien valve inside one of these stentless valves, like the Freedom or the Toronto, or especially the mitral flow, these leaflets aren't constrained. So these valves, because they offer better hemodynamics, are often put in patients with small sinus and small annulus. And what happens is this leaflet gets pushed up over the native coronary and could occlude the left main. So if you're going to do valve-in-valve, you have to understand that the complication rates are different with all these different surgical valves. And the hemodynamics can be different as well. And the mechanism of failure is different. The pericardial valves tend to stenose, whereas the porcine valves tend to tear and have AR. The results, the hemodynamics are better in the patients that had AR than those that had AS. But there are a lot of issues, but the key issues are to size the prosthesis appropriately, to position it appropriately. If you position it too low and you can't expand the transcatheter valve fully, you're going to get higher gradients in your transcatheter valve. You have to understand the risk for coronary occlusion, but the biggest factor for valve-in-valve that may limit its real applicability is residual stenosis. You may leave these patients with patient prosthesis mismatch. And this is just from Danny DeVere's VIVID registry. And what you see, especially if it was less than a 23 millimeter valve, the hemodynamics weren't great. You see a large percentage of patients that have mean gradients over 20. Some of them have mean gradients over 40. So you're really not providing any benefit in these patients. So if you put, you have to understand what you're going to get. If somebody has a 19 millimeter surgical bioprosthetic valve, you're not going to get a great result. Now, people are looking at fracturing these valves to better expand them, but that data is still not clear. So if they have a 19 surgical valve, valve-in-valve is not a good bailout. So if someone, and that has changed our surgeons' mentality. So if someone's having a surgical AVR, we try and encourage them to put at least a 23, because that gives us opportunities for valve-in-valve as a bailout. There are also new surgical valves. The Inspiris valve from Edwards has the surgical valve design is such that it accommodates valve-in-valve therapy by expanding. The frame expands, actually. So we're starting to look at this. So you have to think about what your expectations are for gradients, because patient prosthesis mismatch is a real concern. And when you look at this study, this graph from the Vivid Registry, when you look at mortality, in patients with a less than 21 or less, the mortality was 4 times higher than those with a 25 millimeter valve. So this patient prosthesis mismatch leads to worse outcomes, and we've seen that in the surgical literature. And then beyond these high residual gradients, there's concern for leaflet thrombosis. You can see this with 4D CT, but this is an explant, and you see all this thickening and leaflet thrombosis. And one reason you may get that, this is from Dr. Yoganathan at Georgia Tech, but see, look at when this valve is not able to expand, you're going to get pinwheeling. You're going to get stasis of flow. You're going to get leaflet dysfunction. This valve is not opening normally. You're going to get poor hemodynamics. So when you undersize a Sapien in a surgical valve, you may get this, or a core valve, you may get this. And this is going to lead to early leaflet failure and leaflet thrombosis. This is a little bit more optimal. This is our stretched leaflet. So the reality is, in terms of durability, we need to collect more rigorous long-term data for valve and valve. There aren't going to be randomized trials. It's going to be our responsibility to collect that data. Another expanding indication is bicuspid valves. And the challenge with bicuspid valves is they're asymmetric. You see here, this is a type 1 bicuspid, and they're typically very large annuli. But there are varying types. This one is a type 1, and that's most often what we see, but there are also type 0 bicuspids without the raphe as well. The question in a bicuspid is, are you going to seal at the leaflet level, or are you sealing below at the annulus? Because if this raphe doesn't crack, the valve will seal here. And so you may size it differently, where you're looking at that dimension. But these valves are often associated with aortic root pathology, with annular dilatation and aortic dilatation. And how you manage that is relevant. And they often have very bulky calcium. And the reason that's relevant is when you have a raphe that's very bulky here, the valve will not be allowed to expand in this direction. So it's only going to expand in this direction. And we've done cases where you see the bicuspid valve sits like this. It does not expand in the other direction. And that increases the risk for root injury, in this particular case, under the left main, under the left coronary cusp, because there's no room for it to expand. So you have to be aware of these risks when you're treating these patients. There have been results with both balloon expandable, self-expanding. Some people have said Lotus has an advantage. How you size, these are all unanswered questions in these patients. But this is an example. This video is not playing, but oh, here it is. You see this leaflet, this was a bicuspid valve, type 1 that we did. We got a little bit of ellipticity, and this leaflet is not opening. So this leaflet is going to guarantee going to thrombose without anticoagulation, but we've also got abnormal hemodynamics there. There is very limited data. This is the largest series, and what we've seen is the annular rupture risks were higher with balloon expandable, but the PVL rates were higher with core valve. Newer generation with Evolut and Sapien 3 had lower complication rates, but there are important concerns that may impact the results compared to tricuspid. The durability question is going to be different. If it's elliptical and bulky calcium, it may have less durability. And then you also have to understand what you're going to deal with the aortopathy in these patients. But it doesn't mean you can't do it. This is an example of a bicuspid that we did. But we do these patients asleep. You see on the balloon expansion, this echo here, it goes relatively circular, so we had less concerns. We did a balloon expandable Sapien XT valve at the time with a good result. We've done bicuspids with core valve, with Sapien, but we generally do it in higher risk patients. In a 75-year-old that's truly intermediate risk and a type 1 bicuspid with heavy calcium, we don't do TAVR. We recommend surgery for that patient. And lastly, the expanding indication with trials that are going on are settings where surgery doesn't make sense. We've always done TAVR to try and replace surgery, but there are settings where surgery doesn't make sense, but TAVR may make sense. And these include asymptomatic patients or maybe patients with moderate AS. And the reason why TAVR can go where surgery does not is TAVR is different from surgery. It's less invasive, there's less pre-procedural mortality and less comorbidity with the procedure. It's better tolerated in case of instability. It's a quicker recovery. And depending on which valve, you get a larger EOA with TAVR versus SAVR. And so one interesting trial that's ongoing to expand indications is the UNLOAD trial. So heart failure is the leading cause of hospitalizations, and it's characterized by increased afterload and sympathetic activity, and often has impaired LV systolic and diastolic dysfunction. Aortic stenosis is also characterized by increased afterload, except it's not at the vascular level, it's at the valvular level. And so we treat the heart failure with beta blockers, ACE inhibitors, other medical therapy. With aortic stenosis, when it's severe, we treat it with a valve replacement. When it's moderate, we watch. But the question is, if somebody has heart failure and moderate AS, is the afterload from that moderately stenosed valve significant enough that they may improve by fixing it? So the UNLOAD trial takes patients with an EF less than 50, moderate AS, and heart failure, and they're randomized between optimal medical therapy versus optimal medical therapy and TAVR with the Sapien 3 valve. The idea being that if you can get rid of that afterload from the valve, patients with heart failure will do better than if you don't. So we'll see what this trial results show. This will take another couple of years to enroll probably. The other population where we don't do surgery is asymptomatic AS. There's been multiple registries that have suggested that the asymptomatic AS is not so benign. This was a meta-analysis by Philippe Generoux, where he published in JACC, where he was looking at 4 studies, a 3.5-fold increase in all-cause mortality with medical therapy in asymptomatic AS. So the early TAVR study is taking patients with asymptomatic AS, and they're randomized to the standard of care, which is watchful waiting and treatment when they become symptomatic, to treatment with TAVR while they're asymptomatic. So they get either a Sapien 3 while asymptomatic or conventional therapy. So we'll see again, maybe we should be treating these patients earlier. And those are all important questions. So these are several new indications where TAVR may go where surgery is not. And beyond the existing indications we've already evolved into, such as valve and valve and lower risk populations, bicuspids, it's going to continue to evolve, but we have to collect rigorous long-term data. Thank you very much.
So I think we're being told that we're going to go to the Skype talk on tricuspid interventions. So.
Can we have Dr. Figula? Can you hear us? What? Yes, we can see your slides and we can hear you well. Oh, I'm sorry about that. maybe I can ask, or our panel can ask a couple quick questions. How do you ensure that the flow from the hepatic veins is not interfered with? One of the challenges with these valves is the anatomy. Where do you land them, and how is the valve designed to sort of not interfere with hepatic vein flow? Yes, yes, we can see it. Okay, and then do you think these patients will need anticoagulation with pericardial valves in a low flow state? Yeah. And in those 25 patients, even though the tricuspid valve still leaked, did you see RV remodeling in those patients? Any other questions? No? Well, thank you so much, and thanks for the effort to do this talk remotely, and I'm sorry you couldn't join us here in Hyderabad. No problem. Thanks again. Take care. Bye-bye. So move on. Dr. Ashish Prasad is going to talk about TAVR durability, definitions, reality, and expectations.
Thanks, Sushil. There'll be some overlap in the slides that I showed and Sushil showed, so I apologize for that. But my focus is going to really, in 15 minutes, talk about what is durability, what are the expectations, and where are we going.
Can we switch to the slides now, please?
So these are, actually, you know what, let me backspace one. Yeah, so this is the background. The problem is the data is really hard to truly interpret because definitions of durability thus far have not been standardized. And to really understand this, as Sushil pointed out, you need long-term follow-up. Both the low-risk studies now have mandated echocardiographic follow-up for 10 years, and that's sort of going to get us more information as we move forward. However, we've known based on surgical history that all bioprosthetic valves are not created equally. I mean, we've had mitral flows that were used in vogue for a while with a median life of 3.8 years before they failed. We had valves like the Toronto valve, which is a freestyle valve, and older valves like the Ionescu-Shelley valve, which all had very high midterm failure rates in spite of showing a lot of hemodynamic promise when they first came out. We do know that all current generation TAVR valves are made with similar materials as surgical valves and now are potentially going to be treated with similar type of anti-calcification treatments like the surgical valves have been. And another intriguing idea is this patient prosthetic mismatch. and that frequently mimics structural valve deterioration because both entities have high gradients and low effective orifice areas. And the last but not the least is that structural valve deterioration, although can be likened to be a binary 20 millimeter jump in gradient from a previously known echo, but it's really a continuous variable rather than just a categorical variable. So what we're really talking about is an intrinsic abnormality with deterioration of the leaflets or the supporting structures, either due to thickening, calcification, tearing, or disruption, which ultimately leads to hemodynamic dysfunction. These are some examples. On A and D, you see tears on the left ventricular and aortic side, respectively. On the right panel on the top, you see a heavily calcified magna ease. And then in panel C, you see a Medtronic engager valve with severe leaflet calcification and restriction. So again, so we all speak the same language here. What we're really talking about is bioprosthetic valve dysfunction, which can be divided into 4 categories. One can be the structural valve deterioration, which is what we're going to focus on. Then you have non-structural valve deterioration, either related to the valve moving, or due to patient prosthetic mismatch, or due to a paravalvular leak, which has nothing to do with structural valve deterioration. And then you have other problems like leaflet thrombosis and endocarditis, which are not the focus of our talk today. So we need to thank Danny DeVere for his work in this field to come up with some sort of a standardized definition and dividing them into stage 0, 1, 2, and 2R, 2RS, 2S, and then stage 3. I won't go into the details of the classification. Suffice to state that stage 2, the S stands for stenosis, R stands for regurgitation, RS stands for both regurg and stenosis, and stage 3 is when it gets really serious with gradients that are in the severe range for both either stenosis or regurgitation. These are the classic echocardiographic parameters. Of course, I won't bore you with the long and the short, but the bottom line I really want you to focus on is this need to re-emphasize the body surface area aspect of these effective orifice areas. And so a large man with a body surface area greater than 1.6 meters squared has numbers that are different than a little lady with a body surface area of less than 1.6. And that's something to consider when we look at and describe these entities. The other piece of the problem that is really not clear in the literature is the fact that surgical valves really had never been studied with the same degree of detail like we've done with our transcatheter valves. The most commonly reported measure of surgical valve durability is this term called freedom from structural valve deterioration. And what that really means is freedom from either severe AS or AR, or a freedom from a repeat operation. Obviously, a lot of patients with severe disease may never have an operation or may have died before they got to the point where they were recognized to have this problem. So the issue is that this approach of freedom from structural valve deterioration clearly underestimates the real incidence of structural valve deterioration. However, we know that there are hypothetical reasons for reduced transcatheter heart valve durability. Some are related to the device, some are related to deployment of how we crimp these valves, and the other may be related to just the interaction between the device and the annulus, because unlike surgical valves, we are not really decalcifying the native leaflet, and there's opportunity for interaction that's unfavorable between the transcatheter heart valve and the native aortic annulus due to asymmetric expansion, as Sushil demonstrated earlier, the stent tip deflection that he was talking about, all of which can lead to potentially concerns about reduced durability. This is again a slide that he showed where you had accelerated fatigue and high stress demonstrated at asymmetric points on the valve leaflets, as demonstrated by Martin and Son in their Journal of Biomechanical Engineering. Again, this is elastin fragmentation and an uncrimped control, and here you have the disarray of elastin. Can you see very clearly after you've crimped these valves. This is a slide that Sushil demonstrated earlier that looked at this whole entity that was first described by Carlos Ruiz and reported by Raj Makkar as part of the Portico study, and then since been duplicated in most other valves, where you have an incidence that we're not really sure what the incidence of it is, but roughly in the 5 to 10% range with some association with neurologic events. As you can see, this reduced leaflet motion is seen with all types of valves, both transcatheter as well as surgical valves. It's usually picked up on a 4D CT. And anticoagulation was associated with resolution of this thrombus in the majority of the patients, as can be shown very nicely in the images on the right. So do these hypothetical concerns clinically make a difference is the real question. And this is another slide that Sushil demonstrated, that TAVI and surgery essentially have similar safety and freedom from long-term outcomes, barring the earlier risk for stroke, bleeding, AFib, and acute kidney injury from surgery. But overall, the outcomes from a time-to-event analysis are essentially the same. Similarly, when you look at PARTNER 5-year data, looking at the cohort A patients, again, there really wasn't any structural valve deterioration that required reintervention out to 5 years, with mean gradients demonstrating a nice decline and staying low in that 10 to 20 millimeter range. Similarly, the valve areas didn't show any decrement and increased from 0.6 at baseline to roughly in the 1.5 to 1.8 range, and we didn't lose any ground over a 5-year period on follow-up in the PARTNER trial. Similarly, the supraannular SIR-TAVI data from the core valve, you see similarly better valve performance than even the surgical valves, with valve areas in the 2.1 range and gradients in the below the 10 range. We also know that TAVR is clearly associated with lesser patient prosthetic mismatch than surgical AVR, and this was demonstrated both in the PARTNER studies as well as by Zorn et al. In the core valve high-risk pivotal study. So since Alain Cribier did the first transcatheter heart valve in 2002, we've come 16 years. His site in Rouen, France, looked at the assessment of structural valve deterioration in balloon expandable valves using the new European consensus document that just came out. And they found that over time, in their experience, which is a single center experience of several patients up to 8 years, there was similar increments in both mean gradient and aortic valve area as seen in the PARTNER and the core valve studies. And the patients and a lot of the patients had in excess of 90% freedom from structural valve deterioration out to 8 years. However, the patients that did show structural valve deterioration had one common feature. They all have patients with renal failure, just similar to the data you would see with surgical valves. Similar to what has been known in clinical practice, in the VIVID registry, Danny DeVere very elegantly demonstrated that surgical valves also have had a median time to requiring reintervention for TAVR with a median time of only 10 years with a clear bell-shaped curve. And similar to what I said earlier, some of these valves deteriorated much earlier and the others sort of had a much longer time to failure. So in summary, what would be a clinical approach to structural valve deterioration in 2018? I think stage 0, 1, and 2 warrant close follow-up and repeat echocardiography, especially once you start getting into stage 2 with mixed disease, and stage 3 is when you really start considering reintervention, especially in patients who have symptoms. This is data from the STS ACC TVT registry, which looked at the multivariate logistic regression model of what the potential predictors might be for hemodynamic deterioration. And what we found was that male patients with larger body surface areas that underwent TAVR with small valves, or who had valve-in-valve implantations, or who had patient prosthetic mismatch, were at risk for potentially developing structural valve deterioration sooner than others. So what would be our take-home message? My take-home message from this talk would be that bioprosthetic tissue valves, whether they're surgical or TAVR valves, are both associated with valve deterioration. Most implanted tissue valves can be treated with a less invasive approach, most commonly a valve-in-valve, of course, with the caveat that outcomes in smaller sized valve-in-valves are much different than the larger sized valves. Intermediate and high-risk older patients, like they have been in the United States, should be safely and effectively treated with TAVR. However, in the low-risk patients and younger patients, and especially in those with some of the things that Sushil talked about, like bicuspids, et cetera, should be not treated until we have better data, awaiting the results of P3 and the low-risk core valve study, which we should have within the next year. Until then, surgery would still remain the gold standard. Thanks for your attention.
It's a great overview, Ashish. I think in the interest of time, we'll move on. And Dr. Gupta couldn't make it, and Dr. Rodriguez has kindly agreed to fill in and give his talk on update on percutaneous mitral valve repair and replacement.
Okay, thank you very much. I'm going to discuss some of the new mitral technologies, and in order to do that, I'm just going to kind of look at the mitral valve quickly and then just show that compared to the aortic valve, it's a little bit more complex, and basically we can divide it into 4 different areas. There's annulus, the leaflets, the subvalvular apparatus, and the ventricle. So if you're talking about technologies to address the mitral valve, they can address any of these components, and of course, a total mitral valve replacement would address the majority of them. Just to put things in perspective, if you look 3 summers ago, Edwards spent $400 million buying Cardio AQ. Abbott bought Sapien and Tendyne. Medtronic then bought 12 for $458 million. And then hardware spent $800 million for Valtech, which then actually that deal fell apart, and eventually Edwards acquired that technology. But that was, and then Boston Scientific went ahead and bought M-Valve, and now they have bought Millipede. But that was around $2 billion, just to put things in perspective of, compared to the aortic market, the mitral is a much bigger market, and the companies are investing more into that. A few years, around 2 years ago, I kind of looked at the list of all the transcatheter valve technologies that are in development. These are the ones that people know about them. And when you look at this, I'll just go through them. Basically, it's around 40-something technologies, plus the ones that we don't know about, and this is just a few years ago. So again, there's going to be a lot of things that we're going to see in this space. So the way I separate it, I just go by different levels of addressing. This is what we call a technology to address the annular as an annuloplasty. This would be an indirect annuloplasty device. The only one on the market is really this Caisson, has CE mark, and there's a study that is going in the US. And basically they approach the coronary sinus to try to cinch the mitral annulus via that way. These are all the trials for Caisson. The problem with this is that it doesn't work in a significant number of patients, and the main reason for that is that the relationship between the coronary sinus and the mitral annulus in most patients, it's around 9 millimeters plus minus 2. So very few patients have a perfect anatomy for this type of technology. However, if you choose the proper patient by either cardiac MRI or other technologies, you may be able to help them with this technology. Again, I don't think it's going to be a big part of the future. So the other option is to go and do a direct percutaneous annuloplasty device, and really the only one currently in the US and Europe is the mitral line. And mitral line, let me see how I can cut the sound on this. But basically, the way it works is you're able to go across, get a needle, and then there's going to be a little pledge it that goes in, and basically what you end up doing is a little annuloplasty, like what we in surgery call the K-annuloplasty, but you end up pinching the annulus in different levels to kind of create an annuloplasty, and you put as many of those as you need. This technology in the mitral has kind of stopped, and this is what they're using, that tri-align that they showed before. That is this for the tricuspid valve. Cardioband is the Valtech technology. Edwards has acquired this. They are going with a clinical trial in the U.S. Called, what is it, Active or so. And basically, this is a technology that allows to put an annuloplasty, so transseptal, so transfemoral vein, transseptal, go into the annulus, and then you anchor this band from kind of trigon to trigon. You cannot put a complete band. This will basically get into the aortic valve and other structures. But for the most part, you can go on. It has this little screws, and you screw in this as you go around. And then at the end, you can cinch it under echo guidance to get the effect. It has different sizes, so you select the size, and then depending on how much reduction you want of the annulus. Mitral clip is probably the most advanced technology, or the one with the most experience. There's over 50,000 mitral clips deployed. And in the US, it's the fastest growing technology. There is a new clip. This is the old one. The new one is the NT, and now there's a newer clip, which is bigger with longer arms. But basically, the technology is you go transfemoral, transseptal, and then you're going to come with your clip device. And then this is a combination of fluoro and echo, but the majority of the procedure is TE guidance. So again, you're going transseptal, regular transseptal approach. Mitral clip comes down, and then you deploy this. On the echo, you can see it coming down now from the left atrium into the left ventricle. You start pulling back, and then you grab the leaflets. Once you're happy with that grasping, then you close it under fluoro, and then you see the mitral regurgitation reduction. You make an assessment for mitral stenosis. No significant mitral stenosis. You let the clip go, and then you decide whether you need another one or not. And most people, the average clip is around 1.8 to 2 now. There's been a little bit more clips as we do more cases. And then you end up with a double orifice. And once you are happy with the result, you detach it, and that's kind of the result you get. And you get reassessed again for mitral regurgitation as well as for mitral stenosis. There are some limitations with this, really calcified valves. You have to have good leaflets, and you can, in your mitral valve area has to be of a significant area to begin with. This is one of our cases, 2 clips, and you can see the clips put here. The reason we have this specimen, this was a bridge to transplantation. We put 2 clips, recovered the patient got a transplant afterwards. There is a new clip by Edwards, it's called Pascal. It is basically similar, but it has 2 little spacers in between, so when you deploy the clip, it has like a little filling in between. There's going to be a trial in the US looking at Pascal, randomizing patients against the mitral clip patients. NeoCore technology is a technology where you go transseptal, and then you basically place a cord to the leaflet that is prolapsing. So it has a needle. You grab the leaflet, then there's a needle that goes through, and then you bring it out of the apex. This is approved in Europe. They have CE mark, and in the US, there's a trial with this. And basically, the approach is through a left mini thoracotomy, beating heart. You put 2 purse strings, and then you basically go with the device, go transapical. You go up to towards the mitral valve, and with echo guidance, then you grab the leaflets. And I'll show you. So here's the device, going across, goes into the left atrium. And on 3D, which is the best kind of views that you can get, you rotate the device so you can grab the leaflet. the device had these lights that they change from red to white. When you have all 4 white lights, that means that you have a good grasping of the leaflet. And then you pass the needles. You get your cords out, and then you tie them on their on their echo guidance. And then the key with this is that you want to overcompensate. So you actually want to bring the leaflet further down, almost that you have a little bit of MR. And the reason is as the ventricle remodels and the ventricle shrinks, those cords would be too long if you don't make them a little extra short. And at the end, you end up with something like this. In the US, that trial is going to be only for patients with A2 and P2 prolapse alone. The Harpoon technology is basically similar to the NeoCore. The difference with this is that you can see here, there's instead of just being the core that goes with one needle, the core goes here, it comes here. Here has like a little pledget or a buttress, and that is just to have a little bit more grasping of the leaflet. And again, the same thing, they come out of the apex of the heart, and the apex you can tie them. The Harpoon has a delivery system through the apex where you don't bleed as much as you do with the NeoCore system. This is finishing CE mark trials, and then they're going to start a trial in the US probably in another year or so. Cardio Solution Spacer, this is off the market, but it's basically like the Forma, which is the device that they show for the tricuspid, but for the mitral, the problem with this is they were having too much clot formation and thromboembolism, so this was only in animals. The only ventricular remodeling device that we have is one for the, called a coapsis, which is actually in humans was stop, and then this Mardial base. But again, what it is like you basically put this little wrap around, and then you can inflate this little gadgets that shrink the ventricle. Again, this is only in, I think there's one clinical trial. I don't know where this is going. I don't think there's a lot of activity in this trial. And obviously the big push is for the transcatheter mitral valve repair, just to reproduce what we have done with the aortic valve. These are some of the devices that are available. I'm just going to show you the 4 that are in clinical trials now in the US. The Cardio AQ, which is the one that was bought by Edwards. Advantage of this is they had transeptal technology. 12, which is now the Intrepid trial, which is the Medtronic Valve. Tendyne, which is Abbott, and Caisson. The Tendyne, all these 3 are transapical. Cardio AQ is coming with a transeptal, and Intrepid is also coming with a transeptal. Caisson is already transeptal. The Tendyne has this little gadget that gets anchored into the apex of the ventricle, and it fixes the valve in place. I'll just show you one of them. This is an animation of the Caisson valve, and the reason I'm showing this is just so, again, this is transeptal, and this is a modular system. It has 2 devices. So you basically put the anchoring device first, and then you put the valve. So you go transeptal, sort of like you do for a mitral clip. You come in, your wire is in the ventricle. This is that anchoring device. The anchoring device is going to be deployed on the valve, and then it has these hooks that come underneath the leaflets. And the other key of this thing of this valve is that it has a device to grab that anterior leaflet of the mitral valve to prevent SAM. Because one of the problems with these valves is that as you push that anterior leaflet, you would end up with SAM. So you have your anchoring device, then you're going to come with your, and then you see this has to be kind of underneath where those commissures are. So now the anchoring device is in place, then you come with your valve. And again, the valve gets unsheathed. Right now they have 3 sizes, they're coming with more sizes. All of these valves, the limitation is the sizes and the delivery systems. So here you have the valve, and then you'll see here is the anterior leaflet. of the native valve, and this is the one now you're going to hook that, and then you bring it away from the outflow tract. Delivery systems on all the other transapicals are around anywhere between 32 and 35 French, so it's a pretty big system. That's pretty much it. Thank you.
So, in the interest of time, I'm going to skip my talk for now and move on to the next session. And if there's time or something, I can talk about that. Thanks so much, Dr. Rodriguez, for filling in beautifully. Our next speaker is Dr. Amit. He's going to talk about, is he here, coronary obstruction of displaced prosthesis during TAVI. Great. Welcome. Thank you.
I have the slides. Thank you. Good afternoon, everybody. Thank you very much for this invitation. And I slightly modified the talk in the interest because coronary obstruction due to displaced prosthesis is a very rare condition, in fact. So I thought, like, why not discuss about the coronary obstruction in a whole, and that assumes more importance than just talking about the displaced prosthesis. Aortic stenosis, if I have to tell, then it's a kind of genetic condition in which there is some amount of aortic remodeling, and there is the longitudinal diameter is decreased. So if you see in aortic stenosis, what happens is this shortens, the coronary height decreases. And this may be one of the reasons why coronary obstructions can occur because of either it may be because of the prosthesis skirt or because of the leaflet movement or because of the calcium. We know that I'll be talking about two valves mainly, the Edward valve and the Medtronic valve. The Medtronic valve, we know that the height of the prosthesis is almost like 45, and the height of the skirt ranges from 12 to 13 millimeter. And the depth that is required to be maintained is 3 to 5 millimeters. So if we see, the height of the coronary should be something around 10 millimeter so as not to close the coronaries with the skirt of the valve. But this is not the only mechanism by which coronary obstruction occurs. Now, if we see, the valve sits in the annulus in this way, and we can see that this is the sinotubular junction, height of the sinotubular junction, this is the height of the coronaries, and this is the sinus of Vassalva. So even if the skirt is like the skirt comes until here, the filling of the coronaries occurs in diastole. So if the sinus of Vassalva is roomy, then the blood can easily flow and there won't be any closure of the coronaries. At the same time, if we see that if the sinotubular junction height is well above the limit of 15 millimeter, then also if the sinus of Vassalva is quite roomy and the coronary height is less than 10 millimeter, the closure is not going to happen. The third thing that we need to note is about the leaflet, the movement of the leaflet while the valve is being deployed. Now, if the valve, when it is deployed, the leaflet comes in this direction, and if there is a heavy amount of calcium on the leaflet, there is a tendency that the leaflet may fall back, also be pulled by the coronary pressure, negative coronary pressure, and chance of closure of the coronaries could be there. So these are some of the important things that we need to keep in mind while we are thinking about doing case, a TAVI case. Similarly, if we go for an Edward valve, then the whole measurement again comes down to something like the coronary height of 10 millimeter, as well as the sinus of Vassalva diameter, and STJ height remains the same. In case we are too confused about whether the coronary is going to get closed or not, then what we can do is, like it has been done over here, while we are doing a valvotomy, pre-valvotomy, you can just do an aortogram and see if the coronaries are getting closed or not. If the coronaries are getting closed by the movement of the valve, by the movement of the leaflet, then you need to take a special care. That is, you may wire the coronary, put a stent prior into the coronary, and when deploy the valve, if the coronary gets closed, you can just pull back the stent and deploy the stent. That's called as coronary protection over here. I'll just show a few cases, and that will clarify us how the coronary gets closed and why not. There was an 82-year-old male, high STS score and Euro score. He had low flow, low gradient aortic stenosis, and balloon atrial valvotomy was performed 6 weeks back. We looked at the functional status, and the patient made a dramatic improvement, so we decided to go for TAVI. This patient had normal coronaries at the time of balloon atrial valvotomy. Now, you look at the CT, it's 24.9 perimeter-derived diameter, a lot of calcium in the sinus of Vasilva, as well as in the LVOT. The calcium extends into the LVOT as well. If we see, the whole of the annulus is calcified, aortic valve is calcified. These are very high-risk cases to do. When we see the height of the coronaries, the left coronary height is quite good enough, and at the same time, you can see that the calcium is extending into the LVOT over here. In the right side, you can see the calcium extends right into the cusp and almost reaches up to the ostium of the right coronary. The height of the right coronary was 9.6. But we thought like the sinus of Vasilva was quite roomy and the height of the STJ was quite good. So we thought, okay, we can get away. But at the same time, we kept in mind that there could be a chance of annular rupture. So we decided to go for a Medtronic valve in this case. Medtronic valve was deployed, and you can see just after the deployment, there was ST elevation in 2-3 AVF, and you can see a lot of chunk of calcium sitting out of there. You cannot see the right coronary artery at all. Immediately, selective angiogram was done, and you can see that the ostium of the right coronary artery has got occluded. Immediately, it was wired, ballooned, and this was, initially I thought like, okay, if ballooning can help, just help it, then I'm going to leave it, but it did not help, so I had to stent this segment, and post-stenting there was a good result. So here you can see that it is the amount of calcium in the right coronary cusp and the leaflet calcium. The height of the coronaries was also less. These were the major factor due to which the coronaries got occluded. Let me show you another case. This was another high-risk case, treated case of CA prostate, and he had undergone PTCA to LMCA to LAD and LCX through bifurcation lesion, mid RCA PTCA, the high Euro score, the gradient were pretty high, decided to do TAVI. You can see in this case itself also that there is a large amount of calcium present. On the right side, the calcium extends into the cusp as well as below. On the left side, the coronary height is okay. Non-coronary cuffs looked fine. We did not expect any kind of problem in this case, particularly until now, I don't know why this problem occurred in this case. As soon as the valve was deployed, the patient was shifted to the ICU, but the patient developed hypotension and required inotropic support, so he was shifted back to cath lab. There was also ST elevation V1 to V6 and AVR. So you can see a selective angiogram. There was some haziness over there, so decided to, the right was normal. The coronaries were wired, and now you can see the thrombus formation right at the ostium of the left main, and the circumflex is closed. So went ahead, dilated the circumflex first, did a kissing dilatation over there. Since it was already stented, decided not to stent any of these arteries, but decided to stent the circumflex because the circumflex was a new occlusion without anything. So finally there was a good result. The patient did well later on. This is another case. I'm going to give a couple of cases with Sapien valve. Now you can see a lot of calcium in the left coronary cuffs extends into the non-coronary cuffs. When you measure the distance between the cusp and the leaflet and the height of the coronary, both were 16 millimeter, high likelihood of closure. This case I picked up from some other friend of mine, and you can see just after the implantation of the valve, there was closure of this left main. Immediately, it was plasty was done with 4 into 12 millimeter of drug-eluting stent, and there was no damage. But here, again, you can see it was because of the large amount of calcium that was present in the left coronary cusp and the non-coronary cusp. Again, here you can see the valve was deployed, but when you see carefully, the valve was slightly at the level of the annulus, and probably with a lot of hemodynamic things going over here, the coronaries got closed immediately. It was plastered with 4 into 12 millimeter stent, and the patient did well. So here it is mainly because the prosthesis here was slightly higher than the annulus, not maintaining the 25% of depth that has to be there. These are some unusual cases. These I picked up from the journals, and you can see that this coronary, the patient had a paravalvular leak, and the leak was closed with AVP2. Just after the closure, the operators did IVUS, and they found that the slit was narrowed with so they just went ahead and plastered the case. So it is a case where there was coronary obstruction because of the AVP2 valve that was used for paravalvular leak closure. This is a very interesting case. Again, I picked up from the net this also. This is like the guy underwent TAVI about 6 months back, and then he developed severe hypotension. During hypotension, there was ST elevation in 2-3 AVF, as well as global ST elevation. So the patient was brought into the hospital. The patient had already stabilized. When aortogram was done, everything was fine. Now you can see over here in the CT that this is clearly a supraannular valve which extends right above the coronaries. This is another case because of the pseudoaneurysm formed while post-dilatation, intraannular pseudoaneurysm, which went on to obstruct the left main, and the patient refused any kind of intervention in this case. The patient was discharged and finally expired after a week. While we consider valve in valve, two things has to be considered, like what the surgeon has done, whether it is an intraannular valve or whether it is a supraannular valve. If it is a supraannular valve, the height of coronaries would have decreased itself. So there is a high chance that the coronaries might get closed. So it is better to use a retrievable valve, whichever you are using, and if the coronaries get closed, just retrieve the valve and think of another way of making the patient, rather than you just going ahead with TAVI. If it is an intraannular, then the chance of closure is quite low. So to summarize, the chance of coronaries occlusion depends upon degree of calcification of the leaflet, annulus to coronary ostia distance, length of the valve leaflet, width of the sinus of Valsalva, height of sinotubular junction, movement of the leaflets during balloon atrial valvotomy, patency of coronaries during balloon aortic valvotomy, expanded height of the intended valve, and whether if we are doing a valve in valve case, then whether the surgeon has put an intraannular or a supraannular valve. All these things needs to be considered when you are doing a TAVI in regard to coronaries. Thank you very much. Any questions will be appreciated.
That was a great talk. Just one comment when you talked about the valve in valve. The other thing that you need to think about is, there are different surgical valves have the leaflet sewn either on the inside or the leaflet sewn on the outside. Yeah. And freestyle valves are a whole different entity. And those are the two additional comments that I would add to the valve in valve, other than a very comprehensive review, I would say. Thanks.
Yeah.
Our next speaker is Dr. Sengoruvilu, and he'll be talking about root rupture and dissection during a TAVI.
Yeah.
Sure. Hey, Ramesh, can you come up?
Hold on 1 second. Is Dr. B.C. Srinivas here to talk about difficult transeptal puncture? Oh, Dr. Srinivas, if you can come up and give your talk now. We're going to move things around just because there's some technical issues. That would be great. Talking about difficult transeptal puncture, LV entry, and failure to deflate a balloon after BMV, and other challenging scenarios. Can we get that mic on? Oh, that's good.
Oh, my presentation is here. Okay. Greetings from Bangalore Jayadeva Institute. A well-executed interatrial septal puncture is very crucial for a successful BMV. And the most important steps in the performance of a successful balloon mitral valvuloplasty is a well-done transeptal puncture. And next critical step is the left ventricular entry across the mitral valve. One can perform interatrial septal puncture in many views, as I've shown here, in AP view, in RAVO view, in LAVO view, or lateral view. But always try to verify in at least 2 views before you puncture, once you puncturing the interatrial septum. And whatever views you are comfortable with, please stick to it, though you can do in all 4 views. With respect to crossing the mitral valve, stillet helps in facilitating the crossing the mitral valve in majority, 80 to 90% of the cases. Only in about 10 to 20% of the cases you need to resort to over-the-wire techniques, which I'll allude to. So this is the way we actually maneuver the balloon. When you move the Inouye balloon system with the stillet in, you get the bobbing movement when you reach the valve. That is when you have to give an anti-clockwise rotation, nearly 2 to 3 rotations on the stillet, and then guide your balloon with the left hand as you give a slight traction, backward traction to the stillet. 90% of the time you can maneuver the balloon with this technique using the stillet. These are the technically difficult situations where one has difficulty in puncturing the interatrial septum and crossing the mitral valve. I'll take you through some of the cases. So look at this case. There is a giant left atrium. In this case, the left atrial size was 9 centimeters. You can see in the left second frame, the course of the catheter, virtually in fact, the IAS is made the right atrium like a crescent. And you can see the course of the catheter. So here, what happens is the interatrial septum is pushed down. It's more horizontal. When you try to puncture here, it virtually dissects the 2 layers of the interatrial septum. It can cause dissection. What you need to do here is to give an extra bend to the broken bone needle and engage into the lower septum, stain the septum before you go through the septum in such cases. When you do that, you look at the left atrium, it is so roomy. So to cross the mitral valve in such a case is extremely tough. What you need to do here, you have to resort to the over-the-wire technique. You cannot use the stillet and cross in these cases. So here what we have done, as you can see in the second, the right, we have actually used the Mullin sheath, and with the help of the Mullin sheath itself, we have actually introduced the steel coil guide directly into the LV, and we have dilated the septum over that with the steel coil guide in the LV, and then balloon dilated successfully. So the over-the-wire technique does help in such scenario. This is another example of a large LA, but if you look at the first frame here, it is a low anterior puncture. When you have a low anterior puncture, it is extremely difficult to cross with a stillet. So what you need to do, the only way you can do is actually loop method. In this case, loop method also failed. Then what else you do? You exchange it immediately, take a JR catheter, and then float a pterymo wire, and then exteriorize it from the right femoral artery using a snare. Then you have the veno-arterial loop in place. Once you have the veno-arterial loop, what you can do, you can straighten out by giving traction on the venous side. And now we have introduced a catheter, and the catheter is in the left ventricle. And through the catheter, we are introducing the steel coil guide wire. And you can see that the loop and the wire is an insurance. So you have insured yourself that even if the balloon prolapses back, you can go over the same wire again. So next, over that steel coil guide wire, you perform the procedure with that, the wire loop is still in place. So this is successfully balloon dilated, and then you can take out the entire system. So this is another way. So in the routine cases, depending upon your puncture site, to facilitate entry across the mitral valve, you can shape the wire. Suppose you have a low puncture, then you give a shorter curve to the stillet. If you have a higher puncture, you give a wide and wider curve. And sometimes we may have to give an anterior bend like that to facilitate entry into the LV. Subvalvular disease is a, for example, I'll show an example. This is the impasse sign. The balloon is able to, we are unable to pass through that submitral stenosis, which is very severe. In this case, it was about 0.6, so it was not going through. So what do we do now? In such a scenario, you float a wire through the submitral and then use a peripheral balloon and dilate it, the submitral apparatus, so that you can pass the INOE balloon and then perform the balloon valvotomy successfully. That is the post-balloon valvotomy result. Similar scenario. Unlike to the contrary to the popular belief, luteum bashers is a very difficult scenario actually to cross the valve. In this case, in this particular case of luteum bashers, we tried through the ASD, but what happened was there is no anchoring of the balloon in the septum, interatrial septum. The balloon used to prolapse back into the right atrium. So what we did, we actually did a second puncture below the AST in the IAS, anchored the balloon and tried to pass. But even then, we were unable to pass because of the severe submitral stenosis. So what did we do? We passed a Terumo wire and then snared it out from the femoral artery. And then from the femoral artery, we used a peripheral balloon, facilitated, dilatation of the submitral apparatus. That facilitated passage of the balloon, and then we successfully did the commissurotomy. Left atrial appendage clots offers another challenge. Here the problem is the passage of the hardwares which we use for BMV can dislodge the clot, causing thromboembolism. So idea here is to avoid the clot. How can you do that? Over-the-wire technique is the best. And here you can see, we have shown here, you can pass that steel coil wire directly into the left ventricle and do the procedure with a wire in place throughout the procedure so that the hardwares do not move. For example, this was a roof clot, which this was a roof clot, anyway, above the level of the fossa valis. So we did a low puncture and over the wire technique we did with a successful balloon dilatation and then continued the anticoagulation in that case. This is an example. You can see there is an appendage clot. So what we do, over the wire technique, and do the procedure over the wire successfully. Dextrocardia offers many challenges. But here, you have to go with the left femoral venous approach, invert the image, and then use the opposite of what you use routinely, and take the help of pulmonary artery angiogram with levopacification of the left atrium, and which will guide you to puncture. For example, this was a situs inversus with dextrocardia. He also had a bicuspid aortic valve with severe AS. So this is the levo phase of left atrium, and you can, with the pulmonary artery angiogram, which facilitated puncture. In this case, I've used a LEVO view. I do both in PA, LEVO and REVO views. In this case, I have taken the LEVO because 1 centimeter below and behind that pigtail, it's a very good position to puncture the septum. So once that done, again, over the wire technique to cross the valve and successfully balloon dilate. Because the patient also had a balloon, bicuspid aortic valve, we did that simultaneously, the aortic valve balloon valvotomy also. So the PA injection does help in setting of dextrocardia. Anomalies of the IVCs, where there is interruption of the IVCs, another situation where you have a lot of difficulties. For example, in this case, there was a interrupted IVC with azygous continuation. What we have done here is we have used the it's not running, it's okay. Okay, we actually used a PA injection with a levophase opacification of the atrium, which we took it as a guide to puncture the interatrial septum, and then did a over-the-wire technique, and then crossed the valve, and then successfully balloon dilated. Similar scenario, interrupted IVC with azygous continuation. As you can see, we have come from the jugular venous approach, and in this case, actually, we have punctured the interatrial septum a centimeter above the level of the aortic sinus coming down in RAO view, then cross with the regular technique of the stillet and successfully balloon dilated. So in a given case, you can change your, based on the anatomy and the needs of the particular patient. So in interruptions of IVC, what we use is either we use a pediatric broken bone needle, which is about 45 centimeters, unlike the adult, which is 71 centimeters, or Endries needle, which is about 30 centimeters long. So this facilitates easy functioning of the interatrial septum. And we also use, in every case, PA injections and opacify the left atrium to mark the septal puncture site. And of course, reduce the curvature on the puncture needle, and direction of the indicator of the needle should be 7 or 8 o'clock rather than the conventional 3 to 5 o'clock. And when we are actually maneuvering the balloon, instead of the anti-clockwise, we give a clockwise rotation to the stillet in these cases. This was an extremely rare case because the entire upper body venous return was to the left coronary sinus with aneurysm of the coronary sinus. And this male patient also had severe mitral stenosis which had to be treated. So the challenge in this case was we cannot go into the SPC because it is only the LSPC which is draining the upper body with a coronary sinus aneurysm. So we had to puncture the interatrial septum with the needle within the right atrium. That was the, so here what I did was to stain the septum. As you can see, that is the non-coronary cusp of the non-coronary cusp, the pigtail in non-coronary cusp. We have stained the IAS and then punctured and then confirmed the puncture. When you do this, it is not in the ideal location. Crossing the valve is extremely tough. Here again, you have to go over the wire technique to secure the, to get into the left ventricle and then perform the balloon valvotomy successfully. So when I was doing a case in one of the labs, the next lab, there was a lot of commotion. A junior colleague called out for help. When we went there, this was a picture. There was a patient with kyphoscoliosis, mitral stenosis, attempting to puncture. Patient was in tamponade. So what do? We get access into the pericardium immediately, decompress the pericardium, autoperfuse this blood through another venous sheath, left femoral venous sheath, and stabilize the hemodynamics. And then studied what's happening in this case. This was a dextroverted heart. You can see the heart is on the right side because there was a lung pathology which had pulled, and on top of this, kyphoscoliosis. Now, how do you plan your procedure, the septal puncture? So what I do is inject against the septum and see the septal orientation. You can see it very clearly, it's a horizontal orientation. So when you're puncturing this, you need to give an extra bend to the stillet. Once you do that, you can engage into the IAS and then get across. After doing that, crossing is extremely tough in these cases. So again, you have to resort to the over-the-wire technique. Over-the-wire technique we tried, but the entire balloon prolapsed back. So what next? So here is a scenario where you can go for the loop technique to cross and then get into the, cross the valve and get into the LV and successfully perform the balloon mitral valvotomy. This was another case. A junior colleague of ours took the case, and you can see the balloon puncture site here. It is very close to the posterior margin. This is calling for trouble. Your septal puncture should be here normally. If it is close to this area, very high chance of stitch phenomena. This was a severe cardiac tamponade due to stitch phenomena. It's gone through the right atrium, pericardial space, and re-entered the left atrium. It's a very dangerous scenario. So what did we do? We left that first balloon stented, and then we decompressed the pericardium and then autoperfused that blood. And through a second puncture, we completed the balloon valvotomy, got the LA pressure down. Now, we called the surgeons. Surgeons, all 4 OTs were occupied. Next 2 hours, they were busy. So we had to do something. So what we did here was to try device closure. The first device which we took, it was not stenting the entire both the rent in the LA and RA. So the first device which we put actually prolapsed into the pericardium. It was between the LA and the pericardium. So what we did, we left that device stenting that rent in the left atrium, took another device between the pericardium and the RA and closed the second rent in the RA. So we could successfully close both the rents through devices and bail out this patient. The last part of the talk is failure of the balloon to deflate. Inouye balloon, when new, this phenomena is not seen. It is the reused balloon actually which weakens the layers and the integrity of the balloon is lost. When you have a rent in the inner layer, that is when the one-way check valve mechanism of the balloon comes into play and you have a phenomenon of failure of the balloon to deflate following balloon valvotomy. This scenario, how to manage this? One, you apply continuous negative suction with 20 or a 50 cc syringe to deflate the balloon, try. If that doesn't work, you use saline and then inflate and deflate and see whether the contrast comes out, and then if you're lucky it comes. Then or attempt to tenderize the balloon and see whether the balloon collapses. Other way is to pass the guide wire through the balloon inflation port. And if there will be kinks. If you can take away the kinks, then sometimes the contrast comes back and then the balloon deflates. Otherwise, hard end of the spring coil guide wire or coronary guide wire through the balloon inflation port, and then you actually rupture the proximal balloon. But what is not recommended is rupturing by overinflating and withdrawing with RA force is not recommended because it is injurious. So what we did in this case is to actually through the balloon inflation port, that is the hard end of the spring coil guide wire, deflating the balloon, and the completely deflated balloon is taken out. To conclude, BMV is a safe and effective procedure over a wide spectrum. Transeptal puncture and crossing the mitral valve remain the most critical steps during BMV. Echo assistance is of paramount importance and facilitates the success of BMV in technically difficult scenarios. Knowing different methods of crossing the mitral valve is essentially in technically challenging cases. Over-the-wire technique bails you out in many cases, and especially in technically challenging cases. In BMV, in complex anatomy, has to be attempted only by experienced operator. Thank you.
Thank you. That was a great overview.